Hello and welcome. And today I'm very pleased to be joined by Mr. Simon Radley, who is a leading consultant on why is it whenever
I'm
I press the record button, I can never say the word. Please say the word.
I'm a colorectal surgeon.
That's the one. And we are having a chat because it is Bowel Cancer Awareness Month. Now, I don't know, I'm not anti awareness months because obviously they do a very important thing in drawing attention, but definitely with all these things, you should be thinking about your health all the time. And I always find it strange, we have a month for this and a month for that, but you're thinking, oh, you should be thinking particularly about bowel because there's so much of it in the news, not just this month, but I think there's more and more. Simon's very kindly come on to have a chat with us about bowel cancer and some of the things that we would have heard in the news. Bowel cancer is the fourth most common cancer in the UK, with approximately, which I find amazing, nearly 45,000 new cases a year, that's a huge amount, isn't it, Simon?
Yeah, absolutely. Yeah, it is. It is. It is. And the important thing to realise, though, is that if you catch it early, it's eminently treatable and eminently curable.
Mm.
And that's the really important thing about bowel cancer. And if there's one message I'd like our audience to take away from this is if you have symptoms, get them evaluated, do your screening, and we'll come on to that, I'm sure, in a minute, because it is so curable.
Yeah, and I think what's really quite frightening, it's the second leading cause of
Mm,
cancer in the UK. So
yeah,
it is absolutely not one to mess around with, or not mess around, ignore,
no,
basically.
no,
I think
absolutely not.
I
No.
think that's really what it is. And we are going to talk about it later because they're saying 94% of cases are for people over 50. But I think I started hearing about it a few months ago in the news about younger people are getting more diagnosed with it, which is concerning that it's younger people, but it's more concerning in the sense that it may be doctors may not think that this could be a problem because you're a younger person presenting with something, they may ignore it. So I think everyone has to be so aware. So should we kick off, Simon, with the screening program that we have in this country, which I believe started a few years ago, is when you were 60, you got that in the post, and
Yeah,
now you're saying it's come down to 50.
yeah. So by way of history, I mean, we used to have quite a crude way of doing the screening test, and that involved getting a piece of card and taking samples of your poo on from three consecutive poos and testing it for blood. Um, the difficulty with that, it wasn't particularly sensitive or specific, and so what we've evolved now is a much better test, which is called quantity. It's a long word, quantitative fecal immunotesting, or what people call as the FIT test for short. And the FIT test just involves taking a single sample of your poo and sending it off to the lab where it's analysed and looked at for blood. And the thing about this particular test is that we can actually measure how much blood there is in the stool. And so we can take a reading, and if it's over a certain level, then you will be called back. If you're part of the bowel cancer screening program, then you'll be called back for further investigation. And that investigation is in most cases, a colonoscopy, which is an examination of the large intestine with a telescope. So that's the QFIT test, which we're currently using. When I turned 60, that's what I got on my 60th birthday, as well as my rail pass and my birthday cards. I had the joy of the QFIT test. We're moving the age down towards 50. In England, I think it's a bit slower in Scotland and Wales, but the idea is that in most parts of the UK, we'll be looking to screen people from the age of 50. The test you get through the post is every 2 years, and you can carry on with that until you're 75. Now, hopefully a lot of us are living a lot longer than 75 these days, and so you can, if you wish, at the age of 75, opt in and carry on taking the 2 yearly tests. And a lot of my patients do decide to do that, and I see it as it's quite a sensible thing to do, really. Um, so the so just with there are a few controversies surrounding bowel cancer screening. So and if you were lived in the United States, for example, you might have your test done every year rather than every 2 years. And also in the UK, we the points or the amount of blood in the stool that triggers a colonoscopy varies in Scotland, Wales, and England. And I think that just simply reflects the availability of the colonoscopy services in those areas. But it is also a significantly higher level of blood has to be present uh, in order than, for example, in the United States. So in the United States, their cut point for a colonoscopy would be 20 micrograms per gram of stool, whereas in England at the moment it's 120. That's right, 120
Wow.
micrograms per gram of stool. So that so they have a much lower threshold for investigating you. Obviously, that will mean that you're going to need to do a lot more colonoscopies on people than you perhaps would in the US compared with in the UK. But we know that 45% of cancers in the States are picked up through the screening process, whereas only about 10% are in England. So you more regular screening will actually deliver more results in terms of picking up cancer, and that's really
And,
that's really
and
important.
what sort of yes, so we think, oh, that's really good that we're getting screened, but just because you've been screened and you might have symptoms and they say it's fine, don't presumably accept that at all.
Yeah, absolutely, Katrina. For those of us who've had the test, you'll have read at the bottom there the letter that comes through it says actually if you have symptoms, if your test is negative, still please seek advice because that is absolutely critical. And about 1 in 10 of the bowel cancers that we see will have had a negative bowel cancer screening test within the last 2 years. So it is really, really important that if you have any symptoms at all, that you go and seek medical advice, um, either from your GP or a hospital specialist.
And what sort of, I mean, I don't know if it's controversial, but I mean, what sort of generally would you say would be a safe level? So at the moment you're saying it's 120, which is obviously too high.
Yeah.
What
So
if somebody came to you and you did something and it was at 80, would you have a little warning going up in your head?
I'm sorry if they're
If their test result was 80, they had a score of 80 of whatever the blood count is,
so
would
yeah, I would screen it. I would screen or investigate anybody with an abnormal fecal immunotest. Yeah,
yeah.
and certainly, certainly most of sort of Australia, USA, as I've mentioned. I think Ireland, uh, Italy all use a cut point of 20. So for investigation. So if you have a patient with a raised fecal immunotest of 20 or more in their screening programs, they'll all get scoped.
Wow, that's a big difference, isn't
It
it?
is.
Like that, I can see there's the positive because you've got a screening, but the negative is you could just think it's fine, as we just said
Yeah.
earlier. So yeah,
And what I'm sure I mean, one of the issues, I guess, is resource and colonoscopy, which is the test that we've got at the moment to look at the large bowel is I would describe as labor intensive, and it's quite in a sense it's an invasive procedure as well. And so you have to take some bowel preparation to clear out the bowel beforehand. Then you come up and we pass the telescope around the bowel and we check it out, and hopefully it's all fine. Um, but there are small but rare risks associated with it as well. So, uh, you know, it's a big, there's a big resource implication, and so, and being able to, but hopefully over a period of time, we'll be able to bring that screening threshold down to nearer the threshold
Mm.
that other countries use.
Mm. And then, one of the other things that we mentioned when we started chatting was about more incidents in younger people. So the average age, well, easily the average age is over 50
Yeah.
for cancer, but clearly it is coming down. And what sort of A, what sort of age, and B, why?
So, I mean, I think we'll see cancer. It is definitely recognised that the incidence of bowel cancer has increased in the under 50s, whereas it seems to be dropping in the older age group slightly. And I think there are reasons for that. The main reason I think in the younger age group might well be lifestyle related. Um, it, uh, processed foods, etc., alcohol, um, but and obesity are probably the really important lifestyle factors. But when you ask about age, well, I've seen I mean, I only have an adult practice, but I've seen patients as young as 18 over the years with bowel cancer. Not all, and in some cases there may be a family history, so there's a genetic reason why they might have it, but in most cases they're not. And of course, one always remembers the really young people who've had bowel cancer because they really stick out against the most of the patients who are much older who develop the disease. So the incidence is increasing in younger people. I think it's probably lifestyle related as much as anything else, and that highlights the reason for whatever age you are, if you've got uh, bowel tummy symptoms, that you need to get those looked at and discuss it with your GP, or discuss it with a specialist, and we can investigate appropriately. And actually, it doesn't necessarily have to be a rush to a really invasive test. And the fecal immunotest we use for looking for blood in the stool in patients who've got symptoms. And if you have a patient with symptoms and the fecal immunotest is negative, and in this instance we're talking less than 10, then the chances of you having bowel cancer is less than 1 in 1,000. So really very low indeed. So it's worth getting checked out. If you've got any symptoms that are worrying you at any age, you should get checked.
And the one thing, I know it sounds really obvious, is that we haven't actually mentioned what the symptoms are. And I think we all know, yes, if you see blood, but there must be other symptoms other than that one.
So I'd break it down into the sort of specific symptoms that you might expect from a bowel related problem, and that might be a change in your bowel habit. So you might be a once a day person, and then suddenly find you're going more frequently, or your stools are a bit looser. So that's sometimes it might be you're passing stools less frequently, or finding difficulty actually getting the stools out. So change in bowel habit is really important. The second specific thing, as you pointed out, is blood in the stool. So that might be blood mixed in with the stool, or it might be blood when you wipe. Um, Tend to get more worried about blood that's actually mixed in with the stool, and particularly if it's darker blood. But any type of blood that you see, you should seek some advice. So those are the two really specific things to the bowel. Then unexplained abdominal pain. Um, Bowel cancers, unless they're getting quite big, tend not to cause a lot in the way of pain, but you do see people from time to time who present with the change in bowel habit and pain. Loss of weight is another non-specific symptom that can be associated with bowel cancer. Anemia, so where you're losing blood in the stool and you're not aware of it, can lead you to be anemic, and then you might get symptoms such as tiredness and lethargy, and in extreme cases get quite short of breath, or even get chest pain with it. So those are the sorts of specific and general symptoms that we look for. And you should, if you've got those symptoms, you should go and see your GP. And in most cases, your GP will organise for you to have a stool blood test, a fecal immunotest, and based on that, we'll decide how quickly you need to be seen and referred to see a specialist.
It's interesting because I do a lot of these chats, and lifestyle really does boil down to being a big problem for people. And obviously, our
Absolutely.
lifestyle has changed so much in the last 20 or
Yeah,
30 years. So lifestyle is sort of a really big deal, isn't it?
totally. And I mean, my research of 20, 30 years ago, we were basically looking at diet-related factors in bowel cancer, uh, and I was specifically looking at one particular thing, but the background to this was the relationship between diet and bowel cancer. So there was a big thing about red meats, but the evidence would suggest processed meats are much more of a worry. We know that obesity, there's now a greater association with that, with obesity and bowel cancer. Excess alcohol intake and smoking are all associated with an increased risk of bowel cancer. So I think, yeah, absolutely, and one of the things I think we all become all become these days, certainly I have, is more of lifestyle doctors as well in the clinics, and trying to school our patients right when they come about not just what they've come to see you about, but looking at whether they can do things to improve their lifestyle. And I always emphasize, particularly for the bowel patients, the importance of carrying on with bowel cancer screening.
And I think also on a general note, that the symptoms that you mentioned are sort of could be precursors to lots of things. If you have any of those symptoms, just go and speak to a doctor because they'll have heard it all before,
Yeah,
seen it
yeah.
all before, but for goodness sake, just go and speak to someone.
And the most, yes, and absolutely, and most patients I see that come through my clinics, who have been referred by their GP because they're worried about having a bowel cancer, will not have a bowel cancer, and it's down to something else, whether it be if bleeding might be from hemorrhoids or another cause. Or they might have irritable bowel syndrome or diverticular changes in their bowel. So there's a whole host of non-cancerous things that
Mm.
could be causing the symptoms that deserve investigation, and then you can treat or reassure your patient as you need to. So it's really important not to be shy. Get a diagnosis, find out what's going on, and just be reassured and treated quickly if necessary.
Brilliant. And we've managed to do all of that without saying breaking the taboo.
Yeah, breaking the taboo. Well, well, we both know what we think about that. I think, as you say, it's much less of an issue than it used to be. I think we're all a lot happier. I mean, I talk, it's easy for me. I talk about it every day, but I think a lot more people are a lot more comfortable. The groups that we really want to get into are blokes of my age, I suppose, and make sure that they follow the bowel cancer screening pathway, particularly, and go and seek advice and report new symptoms. And it's a much easier to get seen. You can get seen quickly, you can get treated quickly, and if you're treated quickly and it's caught early, you've got every chance of being cured of it.
Yeah, no, that's brilliant. And it's nice to hear you say the word cured because we don't often use the word cured.
It's a difficult one, and I guess bowel cancer is a cancer that it behaves in more predictable ways in some ways than some other types of cancer, like breast cancer, for example, that can come back many years later. We tend to find that if you've been treated for bowel cancer and it's all been removed and you remain clear, by the time you've got to 5 years afterwards, the chances of it coming back are really getting pretty close to zero. It'll never be absolutely zero, but pretty close to zero. It's
Mm.
important though, even after you've sort of had that all clear from the original tumor that was removed, to to maintain surveillance of on the bowel that is remaining, because obviously if you had one, you can always have another. And it's
Mm.
important to make sure that that doesn't happen and hopefully prevent it. So yeah, but so much has changed in bowel cancer treatment since I was training and since I first became a consultant. We've got new therapies, which means we can get amazing responses, even complete responses to some types of cancer with some of the newer therapies that we've got. And we also work much better together in teams. So I work with oncologists and radiologists and radiotherapy specialists so that we can also, we have meetings every week. So we sit around and discuss individual cases so we can work out what the best therapy for any one individual is and offer those options to our patients. And even where we can't remove it all, we have, I say this quite often to patients where that often we have, I found now we have patients living with the cancer rather than immediately dying from it. And that's been a big change in my lifetime as a consultant surgeon.
Mm. And I think that should give people, a lot of hope. There is a lot of hope now, isn't
Yeah,
there?
there
For,
is,
for
there
sure.
is,
So yeah.
there is.
Anyway, Simon, thank you so much for your time, because I know that you're in between operations and all those
Yeah,
good things. So we won't hold you up.
yeah.
And thank you very much for your time.
Thanks, Katrina.
Thank
Thank you for
you.
your time.